Good afternoon, everybody. This session is ready to begin. This session is sponsored by Symphony Care. Our thanks go to Symphony Care for their support. Joe Porter from the Institute for Health Policy and Practice at the University of New Hampshire and co-chair of the APCD Council will moderate this session. Joe?
Great, thank you so much, Norm, and thanks everyone for joining us today. We are very excited to continue the conversation we started last week and throughout the conference around data quality, a key component of any data use. And we have three terrific speakers speaking specifically about provider and payer data and issues around quality of those data sets. So we will set this up where each presenter will provide some content. We'll do a little Q&A. We may have to cut the Q&A a little short in order to make sure we have room for all of our speakers to speak, and then we can regroup around any Q&A at the end. So please feel free to use the chat function to offer your questions, and we will be watching those very closely. So with that, I am very excited to start our panel. We're going to start with Awana Krishnan, who is with HSRI. She has a tremendous amount of experience in this work, so we're very excited to hear from her, talking specifically about some of the provider work that they've done. Awana has worked on multiple states, data sets, including Colorado and Maine, and she has also done work with SAMHSA and data related to substance use prevention performance. We are thrilled to have her. I'm going to turn the screen over, and Awana, please take it away.
Hello, everyone. Just a moment while I share my presentation. Okay. Hi, everyone. I'm excited to be presenting today on creating a path to reliable provider information. I'll be speaking on this topic on behalf of our team, the Population Health Team at HSRI, and we'll focus on examples from the All Payer Claims Databases, or APCD. Our team has collectively experience working with APCDs for the states of Maine, Colorado, New Hampshire, and just starting up with Oregon APCD this summer. There are three main objectives for our presentation today. First, to examine the complexity of the provider information in APCDs, not an exhaustive list, of course, but highly relevant examples that we have encountered in our work. Second, to provide an overview of the two distinct approaches for organizing provider data, creating a provider index versus creating a provider directory. And third, to present our perspective on the value and importance of the NPI, the National Provider Identifier, and the system that assigns the NPI and maintains the respective records, which is NPES, or the National Plan and Provider Enumeration System. To start, let's consider two questions, and I invite each one of you to think for a moment what your answer would be in the context of the healthcare system. What is a provider, and what is the provider universe? When I started to work with healthcare data, the response seemed simple, since in my mind the answer was physicians and the universe was all physicians. Of course, my understanding has evolved considerably since then. Healthcare providers refer to physicians, nurses, medical students, suppliers, clinics, hospitals, hospital departments, and so on. And there's one other important aspect to the response that has become clear, and that is part of the response burden, is in understanding and defining the specific context of these questions. What are you looking to do with the provider data? What is the specific use case for these questions? The answer may be different depending on whether you are researching hospital expenditure trends, for example, or interested strictly in the utilization of ultrasound imaging procedures, or if you are seeking to inform healthcare consumers of the primary care providers in a 5-mile radius from the consumer's home. So our clients and their data user clients are familiar with us, frequently asking lots of questions to get a better definition of the use case, which in turn will inform what we would recommend to use for provider information. So let's take a quick look at the provider information submitted on ABCD claims and other records. Globally, looking across all medical, dental, and pharmacy claims, and across institutional and professional claim layouts, we have quite a few sets of provider elements, as you can see. For each provider category, you see a particular column in this table, and it goes from billing providers all the way through pharmacy providers, the latter, of course, being present just on pharmacy claims. There's a mix of organizations and individuals represented in these elements. For some categories, we would expect strictly one or the other type. We receive information such as identifier codes, names, address information, as well as specialty information in some cases. Two aspects that would be important to highlight here: the service facility location set of fields may or may not be present on the ABCD submission layout. We've seen both scenarios with our clients. The address information we see on claims should not be viewed as equivalent of the physical location where the service took place. Even for layouts that do include the service facility location, submitters are instructed to populate the fields with the billing entity if blank or otherwise not specified. So what we would be able to say is that the ABCD contains indicators that help suggest the location of service, but we would not be able to distinguish when it is not present. When looking to define providers and the provider universe in the context of ABCD, there are two organizing approaches that we see, and our team has experience with both. One is the construction of a provider index, which represents an inventory of the provider units that are submitted on ABCD records, accompanied by provider details such as the provider name, address, taxonomy information, etc. The construction of the provider index is part of our standard ABCD offering for our clients. And second approach, constructing a provider directory, which goes beyond simply enumerating the provider units and includes information on the provider nesting, such as linking a physician to their place of employment, the hospital or physician group, along with enhanced provider details, which can be anything from, let's say, provider names that are tailored to a specific audience. So for example, concatenating last and first name to display on a website directory of cardiologists, for example, and all the way to a custom listing of all the specialties that a particular individual provider or a particular hospital may offer. Constructing a provider directory is not part of our standard ABCD offering and may be developed if and when a use case arises. So back to the use case of creating a provider index in the context of ABCD data. Where would we start? Just looking at this table, or just looking at the different elements that are present, we would start by evaluating all the different provider-related elements submitted, and either submitted or mapped into the ABCD layout from commercial and public payers alike. Clearly, as you can see, there's one common element, which is the NPI across all of these different provider categories. Rarely, and most likely for earlier data in the ABCD, sometimes the NPI may not be present. We have evaluated the payer assigned provider identifier as well, which you can see as the provider num in this table. One challenge with these payer provided identifiers is that it identifies, as the name says, it identifies providers just within the context of a specific payer submission. And at times we have found that it may represent a different entity than what is represented in the NPI. So we have examples where a particular rendering provider may have the NPI represent the individual. However, the provider num would represent the facility. So the umbrella facility where that individual provider works. So in that case, the rendering provider num links to hundreds of NPIs. So in this scenario, just to recap, in this scenario, the provider name would represent a facility, whereas the NPI on the same record would represent an individual. Provider names, we also found that at times can be, for individual providers, can now be concatenated in a single field. So instead of submitting separately first, middle, and last names, they would be all concatenated into the last. There can be also numerous misspellings and inaccuracy present in the name field. So to conclude, for the purpose of indexing the provider entities that are present on APCD claims, we concluded that the most reliable and consistent piece of information to start from is the NPI. So in support for our conclusion and just in general, let's just quickly glance at what the NPI is and its history. It's a 10-digit intelligence-free identifier for providers of healthcare services, which was created to improve the efficiency and effectiveness of electronic transmission of health information. Intelligence-free is an important aspect because a physician that will move from state to state, change their name, or change their employment and professional affiliation, and even change their specialty, should be able to retain the NPI that they were assigned in the beginning. So that's a big plus for this type of identifier. Alongside the NPI itself, so NPI, I'm not going to go through a lot of detail of the history, but the compliance deadline was in 2007. And what I want to speak about is the data elements that are present in the NPES alongside the NPI itself. So what we see is information on the entity type, telling us whether the provider is an individual or organization, a set of information on provider names. For organizations, we have the main organization name along with other, and more recently, providers can submit even more than just one other provider name. We see information on the business mailing and practice location, street addresses, other identifiers such as licensing, so Medicare, Medicaid, DA identifiers, as well as licensing and taxonomy information. We also have information on whether the organization is the sole proprietor, it's a subpart of a different organization, and which organization that would be, so the parent organization. Then we also have a set of administrative dates, such as the enumeration, that is the date when the NPI became active, the last update, which gives us information on when the NPI record was last updated in the NPES, deactivation and reactivation if applicable, and more recently, certification date. So the NPES also includes deactivated NPIs. In this case, only the deactivated NPI, so the NPI element itself, and deactivation date is present on the record. All the others, all the other elements are deleted. So we see a lot of value in having the NPES available for the provider index creation, and some of the value information that we see have to do with it being available at the national level. It's available publicly at no cost and in a machine readable format. It's also available through a NPI registry website tool. The database is available for researchers and other interested parties to download in a monthly update. So the full NPES database can be downloaded monthly, and there are also weekly updates available for those interested. And it has a wide range of uses, which I could list. So moving back to the construction of the APCD provider index, this is a very simplified processing step outline. We the APCD data gets submitted to us. It goes through data validation. One example is we check the NPI present on claims against the most current version of the NPES list to ensure the NPI is valid. We then construct a provider composite ID, which has a one-to-one correspondence with the NPI for the reasons I have outlined above. So at this point, we have indexed the providers that are present in APCD, and then we move on to the last step, which is to tag all the provider details that are relevant for the respective provider. And in this case, we made the choice to, instead of relying on the data that gets submitted on claims, which, as I mentioned, can have multiple inaccuracies, misspellings, may not be present always. So for this purpose, we rely on the NPES data element, which we refresh quarterly in the APCD data warehouse. So in the end, we construct a provider index, which has one record for each NPI. And alongside the NPI itself, we have all the provider details that I just mentioned. So let's take a look at an example in a context of a generic hospital provider. When we think about the hospital services that are present in the APCD for this hospital, globally across the provider categories we outlined, there would be multiple angles to look at. So we have the umbrella entity for the hospital departments and other service segments such as swing beds, internal medicine, individual providers such as physicians, nurses, and suppliers. And we have information on whether or not it's visible in the APCD. We would be able to know that we can assume actually that these services could occur at one location or multiple locations. So from the perspective of the APCD provider index that we have constructed, each of the facility and individual entities outlined in the top charts would be expected to be present in the index as long as these entities have their own separate NPIs that they are using on the claims submitted to the APCD for this hospital. So the APCD provider index will list each NPI separately on its own provider composite record and would not include any linking information between them. So the nesting in the diagram is not something that the provider index was created for. Rather, the index is, can be used as a quick reference for the provider details in whichever role they may be present in the APCD, rendering, billing, etc. So now moving on to a specific use case, and that is for Compare Maine, a healthcare transparency website that displays the average cost of common healthcare procedure at different facilities in Maine. For this, we work with our client, MHDO, and directly with hospital providers to validate the list of billing NPIs to include an analysis. And early on, we made a decision that the billing NPI would be more appropriate for this type of organization of provider information. We also work with the hospital directly to validate what the facility location address is and to confirm the consumer-friendly display name. So this is for consumer audience, so we want to make sure we display the name of the facility as it makes sense for consumers. And for this purpose, we do not necessarily want to rely on the NPES information. In NPES, for example, we would not necessarily have the most up-to-date information on hospital mergers or hospital name changes due to a health system change. So again, the canonical display name for the facility is decided together with the facility directly. Then we also work with a facility to decide on which analytical grouping makes sense to display for the cost estimate. There are two scenarios outlined here. Either we do a roll-up across all locations, or we do a separate estimate for each location, and the facility weighs in on the respective analytical grouping. And again, this process may seem simple when it's outlined in this way. However, it's time consuming, time and resource consuming, and it has to be redone to confirm the accuracy of all the above anytime there's a new release of the comparator. One other deliverable to mention is that we are currently working with MHDO to develop a provider database that is larger in scope. It will include all the providers in the health systems in the state of Maine. And it will support the management of healthcare provider information in a directory structure. So, of course, the examples that I just outlined are going beyond the construction of the provider index. They're going to constructing a provider directory. It's because it's tailored to serve a specific audience and purpose. So when we construct the provider directory, we take into account external standards and reference information. So for example, state or national inventories of hospitals, etc. We would take into account what the ultimate audience is for this directory, whether it's the healthcare consumers or researchers or health systems. And there are a series of methodological considerations to take into account, whether we want to do a provider directory for the universe of providers in a state or just a subgroup. We need to decide what detail elements to include and maintain, and which custom or standard provider groupings to offer in this directory. So as I mentioned, there's time and resources investment that everyone needs to be aware of for building a provider directory. So a few challenges and limitations to each approach. For the provider index, as I mentioned, occasionally there are absent NPIs, but close to none in recent years. Then using the NPES for the provider name is not always straightforward. Occasionally we have determined that we would rather use the alternate or the doing business as name of an organization. And actually for one of our clients, we do maintain a separate list informed by the respective client where the alternate name is preferred. NPES may be incomplete. For example, while it offers relatively large set of taxonomy information, so the provider can specify multiple taxonomies sometimes, and the provider can specify which one is the primary taxonomy. Sometimes the respective flagging is missing on the NPES record, so we do have to come up with an alternate algorithm for determining a primary taxonomy and then adding to the provider index. And then one important piece is that NPES recency of updates. Just quickly glancing over 3 different states and NPI records for these states, both individual and organization providers, we can see that only roughly around 9 to 13% of these NPIs have the records updated in 2019. So depending on, this shouldn't necessarily be viewed as updates that should have been made in the past year, but just to give you a sense of when the last update date are in terms of the NPES records. So more than half of NPI records for these 3 states have been updated prior to 2016. And as I mentioned, this is both for individual and organization records. It looks similar. So back to challenges and limitations. For the provider directory, one of the key challenges there is we have a lot of difficulty in determining the relationship between providers, not only between individual providers and their employment places. So whether they work in a group, a provider group, or in a particular hospital, this may be difficult to determine when looking strictly within the NPES or when looking within claim records. It can be time and resource intensive, as I mentioned. So even for a smaller scope provider directory, it would still require time investment, especially if we want to have a feedback loop with the respective providers. Maintenance may not be sustainable. And then one question that comes up often is, okay, but does this provider directory work scale? And to that end, I think we have to think about what is the ideal national provider directory. If we wanted to build a provider directory, what should we do to be able to do that? So I'll get to that, but just to start on our recommendation to build a reliable provider information, first, looking strictly within APCD, we would monitor the APCD submissions to detect data quality issues and changes over time between payers to refine intake validations. Then we would work with data users and our clients to improve the knowledge and understanding of the provider complexity. As I mentioned, I think we want to highlight the importance and value of the NPES. And we think it's a great resource that's available nationally, and any opportunity that you and I have to increase its completeness and accuracy, we should take advantage of. So collectively, not just us, but other members in the audience, we should continue to explore pathways towards a national provider directory based on best practices, streamlined validation processes, and other resources such as databases for provider licensure information, DA databases, and other provider information available. I would like to thank my contributors. The following members of our team have contributed to this presentation: Kevin, Kristen, Sharon, Melissa, and Leanne. And thank you to the audience. Let me know what questions you may have.
Thank you so much for that. That's terrific. Actually, I'm going to ask folks to hold their questions and we'll do them at the end, only because I do want to ensure that in the next 40 minutes or so that we have together, 35 minutes or so we have together, we can get through the content of our other presenters. So very quickly, I will introduce Dave Schaefer, who was with the Lewin Group. Similar to Pat's conversation with the session earlier today, we are scanning all over the country for our presentations today. So we started in Massachusetts and we're going to go over to Iowa now and listen to some conversation with Dave, who is a managing consultant with the Lewin Group, and he has a tremendous amount of experience, including with some Medicaid ACOs and other alternative payment model programs, focusing on quality and performance measurements. So we are going to let Dave talk to us about some provider data quality issues as well. And again, if you can put your questions in the Q&A, we will get to them at the end. So without further ado, Dave, please.
Thank you for that introduction. And thank you for attending the session today on data quality. Today, I'll be discussing approaches and examples of data quality testing we use in our projects at the Lewin Group. Our team at the Lewin Group works with several state Medicaid agencies, CMS, and private payers on a wide variety of projects, including implementing and evaluating alternative payment programs, state waiver programs, and performance and quality measurement. All of which of those, the quality of the data we use is of utmost importance. As many of you experience, managing data quality is an ongoing challenge, from concrete data challenges such as state-specific or organization-specific codes, recognizing those codes, erroneous or missing data, to gaining buy-in and priority from data contributors for an APCD, for example. All of these affect the quality of the data we use to make informed decisions. These approaches are not intended to be a complete set, but hopefully they'll help you generate ideas for you and how you can use them to improve the quality of your work. The agenda that I'm showing is just a brief overview of the topics I'll cover today and those approaches. But before I begin with those approaches, as much as ever today, we hear and we need to emphasize the use of science in our decision making. But it's important to remember that science is a method. It's not a belief system. There are steps that we follow in the scientific method. We all remember from junior high school science class learning about the scientific method. This method is applicable to data science and therefore data quality as much as it is to physics, medicine, or any other scientific field. This is an aspirational goal, however. We don't always use the scientific method in our decision making, but I believe it's important to use the scientific method in our approach to improving the quality of data we use in our decision making. There are aspects to the process that need to be considered. It should be thorough, repeatable, intuitive, responsive, and timely. Now, timeliness is an aspect that can run counter to other considerations. So we work on projects and we have schedules that need to be followed. Data contributors submit their data and it needs to be received, intaken, validated, tested, processed, all in a very short period of time, usually. A data quality process needs to be efficient. So it's as important as an aspect as any other. If issues with the data, say from one data contributor, can't be remediated, the use of the data oftentimes needs to be delayed, squandered opportunity. Therefore, the data quality testing and analysis needs to be completed as early as possible after receipt of the data to avoid these issues. This is a 5-step approach we've used and we take to validate, test, and identify data quality issues in the data that we receive. This 5-step approach ensures detection of data errors, absence, abnormalities, and inconsistencies. We'll use key ratios and distributions based on industry standards and experience, and also use trend analysis, as you'll see in some of the examples from cycle to cycle of receiving the data, whether it be monthly, quarterly, semi-annually, or annually. Step 1 is really the most basic of steps in data quality assurance. Structural and file layout compliance just simply confirms that the data is properly formatted and structured. This can include the control totals that we frequently require in the data that we use, just to make sure that first step, that the data that we expected to receive and that was sent is what we actually received through the transfer process. And for the other steps in this approach, I'll show examples from our work. But before I do that, just a quick note on the tool set. At Lewin Group, we are a SaaS shop, so we use SaaS for data analysis and statistical work. There are plenty of other perfectly good options to use. For data visualization, We typically use Tableau. The examples that I'll be showing you are built in Tableau just for the data visualization, the ease of identifying abnormalities and data quality issues. You'll need to select the use and use the best tool set available in your organization, of course. So back to the 5 steps in data quality testing. The second step here in our process is checking field completeness and uniqueness. The analysis drills down to different layers into the quality of the data. So at the top, we're selecting the claim type, in this case, outpatient facility, and comparing current results with previous data submissions, checking for the consistency of the data that we receive. We expect the data to be consistent generally, unless there are unidentified circumstances. You just normally, you'd normally use variation thresholds here, say standard deviations, or experience to determine when to highlight variation as a significant outlier. At the second layer, we're drilling into that outpatient facility and looking for relationships with other data elements, such as, in this case, data or provider types with claims at those outpatient facilities. So you can make sure that the provider types that you'd expect would be submitting the claims under that claim type. So at last Tuesday's presentation on improving data quality, Mackenzie Malone spoke to statistical methods to identify outliers and potential issues. If you didn't attend that session, I'd recommend viewing it in the archives. It's very helpful in understanding and identifying some statistical methods to use and to test the data. Next, the third step, we look at code and value validity. So we'll check our data elements and values against industry standards and references. For example, up-to-date ICD-10 code sets, HCPCS and CPT procedure code sets. We'll check those against the full and complete sets published by the code set owners and stewards. For provider data, we'll use, as Ioana was talking about, the NPES, the National Plan and Provider Enumeration System, to check provider IDs. Within that NPI, there is a check digit methodology. It's called the Loon formula, where you can use that to ensure that we're collecting a valid NPI just at the start. So when checking against standardized code sets, of course, you'll need to be aware of the use of state or organizational specific codes. I mentioned those earlier. This is some upfront work that will pay off in the end. Identifying those after you've received the data often leads to just interesting challenges. Better to identify those state-specific codes. Medicaid tends to do that frequently, use state-specific codes in their data. The next step is testing for data reasonability and appropriateness. The data quality process can and should use common Six Sigma methods as well. In this example, we're using run charts to check the reasonability of quarterly submitted data, submitted claim volume, average cost, total cost of the claims. So here the claim is filtered by type of service. We're looking at ancillary service claims here. In the top chart, and on the right tail, we see what we would expect, the effect of the claim run-out period. So we're advancing, these two lines advance the data contributions 1 quarter. So we're seeing that quarter advance, and we see that similar volume tail off, and we can see the claim lag, at least visually, is similar from quarter to quarter. Finally, it's important to check referential integrity between data sets, tables, and fields. For example, checking to see that all health plan members with a medical claim actually had coverage during the time period and appear in the membership tables. Or checking to see that a member with a paid prescription drug claim that those members were enrolled in a benefit class that covers prescription drugs. Just those logical type of scenarios that you want to test to make sure that they're making sense in the data that were received and testing. It's really thinking of scenarios at this step to test that referential integrity and the data relationships. It goes beyond the simple control totals, the valid value checks and consistency that we talked about earlier. To conclude, I've reviewed some techniques and tools we've used at the Lewin Group to test and improve data quality. Naturally, the approach depends greatly on the purpose and requirements of the analysis in your organization. For an all-payer claims database, where people, organizations, governments rely on this information to make evidence-based decisions, it's important, as all of us know, to have a sound process and methodology to ensure the quality of your data. So thank you with that, and I'll turn it over for the next session.
Joe, you're on mute.
Thank you, Heavens. So we're going to move things over to Sterling Peterson with the Office of Healthcare Statistics at the Department of Health in Utah. Sterling is an old friend of the NADO conference and is often a presenter, so we're very excited to hear Sterling talk to us about provider-supplied payer typology work in hospital discharge databases. And again, please put your questions into the Q&A and we should have a little time at the end for some questions. So Sterling, please.
Can you see my screen?
Yes, we can.
Great. That means I pushed the right button. Thanks for that introduction. What I'm going to present today is fairly high level. I hope it's informative. And if you have any questions, feel free to ask them either at the end of this session or reach out to me directly. Excuse me. So first few slides here, just kind of go over the mission and strategic objectives of the department I work for, which is the Utah Department of Health. And happy to visit with you about those at another time. Today, I'd like to focus on payer topology and requiring our data suppliers in Utah to provide that, particularly the Utah hospitals and surgical centers. So like many states, the Department of Health in Utah has collected inpatient, ED, and AMSurge encounter data from hospitals and other facilities for several decades. I think we're approaching 30 years, and that's a long time. I believe Utah was one of the first movers in that space, but that doesn't mean that all of our practices are always at the forefront. And because of that, in 2018, we decided to make some substantial adjustments to the technical specifications we were using to collect the hospital discharge data. One of the key changes, among many, was to collect payer topology from each of the hospitals. As I point out in bullet number 2 here, almost all research and policy use cases for this data rely on accurate payer classification. There are very few exceptions. And so we need to, whenever we switch methodologies for collecting that data, we need to make sure to do some analysis to make sure we didn't cause any inadvertent breaks in trends. So we added payer topology alongside the previously collected free text payer string. Unlike other states, for most of the last 30 years, we've just categorized the free text payer strings manually or using a variety of methods and use that moving forward. We didn't require the facilities to actually submit that. So these are kind of the approaches, as I kind of hinted at. The first one was a manually crafted lookup table. We stopped doing this, I think it was about 2016, And when we stopped doing that, this lookup table had over 70,000 entries. This was starting to be problematic because we would receive questions from data users about how and why certain things were categorized the way they were. But when you have a lookup table that big and you have staff changes over the course of several decades, what you end up with is kind of an undocumented list of subjective judgments. And it was just unsustainable and difficult to audit. So we kind of set that on the table, put it on a shelf rather, and we used it as inspiration because there was a lot of good work in there that we wanted to build upon. We didn't want to scrap all of it, but we knew we needed to have a newer method. We experimented with complex regular expressions. And if you're not familiar with regular expressions are built using a regular expression language. And it's a language designed to help express certain patterns in text strings. And it's very powerful. There's a little bit of a learning curve involved. And if it isn't properly documented, it can be difficult to maintain and for future analysts to understand. We experimented with that for a little while. We saw some early success with that, but we kind of put that on the shelf as well. As I note on this slide, we'll probably revisit it in the future because of the flexibility it was giving us. But at the end of the day, we've adopted a simple string matching method for the historic data. When we were developing this in, I think, 2017, HCUP provided substantial assistance, and we're very grateful for their help and guidance in that. It's the current approach we use for the historic data, classifying all of the pair strings. And it's built using SQL currently. And I put a simple example here, and it says when pair name is like wildcard Medicare wildcard, then one representing the Medicare pair topology class. So we've tried a variety of approaches, and then we made this change. We made this change to collect pair topology. For those of you who aren't familiar with pair topology, this was previously maintained by the Public Health Data Standards Consortium, but recently NATO has taken over the maintenance of this, and I think it's a good fit at NATO. I've put a link to their website here. Pair topology has a hierarchical structure, and meaning you can dig deeper and deeper and deeper and deeper into it. Again, we started requiring this to be on all of the encounters we were collecting, but we chose just to use the highest level, and there's a variety of reasons for that. This is just a screenshot from the PDF that you can get on the NATO website. As I said, we used the top layer or the top level. So we just required them to report one, Medicare. We didn't break it into managed care or non-managed care or hospice or dual eligibility or any of the subclasses within that. And these are the top level categories. There's Medicare, Medicaid, other government, Department of Corrections, private health, insurance, Blue Cross, managed care unspecified, which basically means the provider understands that it's a managed care organization, but they're not quite sure if it's government supported or not. That's kind of a tricky one, and we hope we don't get too many of those. And then there's the self-pay, no charge, charity refusal category, and then kind of an other insurance category with workers' comp and auto insurance and others. We also allowed blank or null to be submitted as an unknown value, which actually proved to be a little bit problematic, and I'll talk briefly about that soon. So what I'd like to talk about at this point is just kind of looking at the results. What did the quality look like relative to what we were doing previously? We did a separate analysis for each type of encounter. The inpatient was its own group, emergency department, and ambulatory surgery. They're each independent groups. In Utah, we still have a lot of independent ambulatory surgical centers. You know, they're probably, like most places, they're being bought up quickly by larger organizations, but we still have a lot of those in Utah. And the level of sophistication varies greatly. Those that are kind of part of a bigger entity, they have higher levels of technical sophistication and are able to work with programmers and IT staff to really enhance provider or data quality. But in other cases, the ambulatory surgical centers are these smaller shops with, you know, maybe a few doctors, a few nurses, and a receptionist. And in those cases, we work really hard in Utah to cater to the lowest common denominator to make sure that they can be successful at submitting data when they don't have programming staff, when it's just a backroom billing clerk trying to pull together these reports. So we found a strong concurrence between the reported topology and the results of our string matching algorithm for most of the major categories. There were some misclassifications for smaller categories, corrections in particular, and also this last bullet point, because we initially allowed unknown as an accepted unconditionally valid value, it led to very low non-empty completion rates for some of the smallest surgical centers and inpatient facilities in Utah. We've since rectified this, as far as I know. I think we made some changes to the thresholds for acceptance, and hopefully this has resolved most of that, but that'll be another presentation probably. So this is looking at inpatient payer topology for the reported versus the imputed being the string matching thing that I discussed previously. And you'll see that for some of these the largest categories, Medicare, we're really close. You know, we're just several hundred off on the number of encounters that were labeled Medicare. Medicaid, similar. Government, which includes TRICARE and Champus, and a few others, really, really close. In fact, in that case, we're only off by 70. We imputed 70 more than what the providers reported, meaning we're probably on the same page. Department of Corrections, it's a smaller group, but we imputed a lot more. As we kind of dove into this, we see that we're actually probably doing a better job than the providers on this. When we see Utah State Prison or Salt Lake City Jail, we put that into the corrections category. And in other cases, in the provider case, they were attributing that to private insurance in many cases. We see private health insurance and Blue Cross Blue Shield kind of have more variance than we'd like. We see only a minimal number of these kind of nebulous managed care, unspecified. And then we see, I don't know, a somewhat concerning level of potential misclassification here. If we do something that a researcher would likely do, which is combine private health insurance and the Blue Cross Blue Shield categories, what we see here is it essentially puts the difference at 0. And that kind of tells us there's probably some fluidity in the way that's being classified by the providers. If we do something similar, kind of binning together the unknown category, the self-pay, and the other non-health insurance category, mush those together, then we see the difference kind of shrink. And this tells us that it's kind of a mixed bag here. There's some fluidity between these groups, and we need to dive in more to understand exactly what's happening here. But it tells me that there are some difficulties in categorizing these particular groups, and there's probably some crossover between them. This is a similar table for the emergency departments. You'll notice that the Department of Corrections in particular has we imputed a lot more than the providers were reporting. That's an important category for some of our reporting. So something we want to look into a little bit more. And the results are very similar. When we mush together the private health insurance groups, we're seeing that difference really shrink down to essentially no difference. Similar thing with the unknown 8 and 9 groups. When we look at AmSurge, unfortunately, there's a large number of unknowns, and that's the reason for that is the lack of a strong threshold for non-empty pair topology in the reporting, which I believe we've since rectified and tightened down. Combine the categories, get within a few hundred for private insurance. And this one's more of a mixed bag, and it's probably largely driven by the unknown category here. We're just not quite classifying these categories properly. So what are the next steps? We want to learn what we can from the payer supplied topologies and refine our current string matching algorithm that we apply to the historic data and the current data, actually, and I'll touch on that in a second. One example is we found flat rate as a raw payer string and realized that, oh, that's probably best classified under the self-pay category. So we moved it in our string matching algorithm. We need to do some manual review on those categories I mentioned before, and need to make sure that whenever we make these types of changes that we apply appropriate validity checks, as was mentioned earlier in this session. It's much easier to deal with data problems on intake than try to rectify them downstream. And this is particularly important for the smallest of AmSurge centers in Utah. And we also need to review the 2019 and 2020 data. There's a bullet point here that I left off and I should have included. It's in our data releases, because this is such a substantial change, we've started releasing both the provider supplied payer topology as well as the results of the imputed payer topology using the algorithm that we use on the historic data. So a data user can actually see any differences and determine if there are any issues and provide feedback to us. That's all I have, and I hope we have time for a few questions. Thank you.
Thank you, Sterling, very much for that. Okay, so I'm looking for questions in the Q&A, and I'm not seeing any right this second. I have a question, and Sterling, you just touched upon it, so I might go to our other presenters quickly first and then come back to you on it, which is, you all made some really excellent points about what you are looking for and what you're doing around data quality issues. And all made the case about the importance of how use cases can sort of drive what you need to be doing in some of those scenarios. So Sterling just touched a little upon what they are doing for a data user, in that some of the imputed and the provider provided fields are being, but for your data users, what sorts of information are you giving related to the work that you're doing on the data quality to the user community for the data that you're supplying back out? Maybe Ioana, we could start with you.
I think we start by providing an overview of the way we construct the provider index into our business rules, which can then be provided to data users in a more user-friendly format, I guess. But we are transparent about the processing that we do for the provider index. And also, similarly for a provider directory, we do include a high-level description of the type of decisions that are made, but not necessarily to the level of detail that I described in this presentation, because there are a lot of evolving decisions, I guess, in the context of a provider directory.
Great. Thanks, Dave. Anything you want to add in our last minute on the conveying this back to the users?
Yeah, just quickly and simply, I mean, I agree with Ioana about the transparency of the data, and I think we all agree with that. I think we have to recognize that users don't see the data from the same perspective that we do. You know, they may not understand the assumptions we're using. And I commonly talk about the effect of the claim run out period and the claim lag, and explaining the issue of, you know, sometimes it takes a full year to receive the full of what we consider to be the full set of claims. So it's sharing information like that, little rules of thumb sometime that you just need to, and there's so many of them that you just can't share them all, but there's just making sure that the priorities are around identifying those most important rules of thumb.
Great, thank you. Well, I know that when Norm reappears, that means that our time is done. So we need to wrap up. I'd like to thank Sterling, Oana, and Dave for their time and their energy pulling this their content together for the session. Thank you all for joining us, and thank you to Symphony Care, which is the sponsor of this session. And I will turn it back to Norm to tell us what we could do from here.
Yeah, so in 10 minutes, we have another round of breakout sessions started, and we want to remind everybody at 5 o'clock Eastern time, we have the award of the Elliott M. Stone Award, and we encourage you to spend 15 minutes with us to recognize those recipients. Thank you, everyone.